Today, I am very excited to present our Grand Round speaker, someone who should be familiar to probably most of you, Dr. Anoop Prabhu. Anoop obtained his undergraduate degree from Cornell and went on to med school at SUNY Buffalo. Following this, he moved to Ann Arbor and the University of Michigan, where he did both his internal medicine training and his GI fellowship. In 2013, we were extremely fortunate to have Anoop be our Advanced Endoscopy Fellow. And while he was our second fellow overall in this program, he was actually the first Advanced Endoscopy Fellow at Mount Sinai to join us by the ASGE match. And we had a wonderful year with Anoop. I can still remember many of the cases and discussions and conversations, and certainly laughs that we had over the course of that year. And I guarantee that if we walk through Endo today, he would still remain one of the historically favorite advanced fellows among our endoscopy staff. So following his advanced endoscopic fellowship with us, Anoop and his family moved back to Ann Arbor, where he joined the faculty at University of Michigan, where he's currently an assistant professor. Anoop does spend a significant part of his clinical time at the Ann Arbor VA, where he holds many impressive titles: Director of Therapeutic Endoscopy, Director of Endoscopy, the Associate Chief of GI for Education, and the Director of Endoscopic Training. And for anyone who knows Anoop, it is absolutely no surprise that he has been the recipient of numerous teaching awards since joining Michigan. He has won or been awarded the Outstanding Endoscopy Teaching Award for 3 of the past 4 or 5 years. He's gotten employee recognition awards. He's really just had a wonderful start to his career. He has published on a wide variety of topics in interventional endoscopy, and currently his research focuses on quality in interventional endoscopy as well as endoscopic education. And today he's going to lead us through a discussion which has really become a hot topic in endoscopy, and that of ergonomics in endoscopy. I know I could certainly have benefited from this, and I am very much looking forward to hearing what he has to say. So with that, we are excited to welcome Anoop back to Mount Sinai and back to New York. Anoop.
Excellent. Can you guys hear me okay?
Absolutely.
Perfect. Thanks, Chris. That was an awesome introduction. I really appreciate it. I'm trying to reconcile the fact that the calendar tells me it's been 8 years since I was there, but it feels like it was yesterday that I was there. It really is an honor and a privilege to speak on this topic, which, as in my role as endoscopic trainer for our fellowship, became a pretty important topic to me and one of my pet projects. In the process, this originally started as a project to teach fellows as I started. And we began to realize that many of our faculty also were having significant issues with ergonomics. And so this has become a programmatic change that we've instituted, and hopefully we can give you some information that'll make it worth your time for today. Let's see if I can get this going. All right, so I have no disclosures. The brief outline, first I'm going to start with what I call the scope of the problem, meaning how often we get injured and what we do or don't do that causes these injuries. We'll then talk about the problem of the scope, specifically design flaws in the endoscope itself, as well as systems-based contributors to injury, which predispose us to these injuries. And then how we can incorporate ergonomics and prioritize what's called a hierarchy of controls, which identifies the highest impact interventions to help us with ergonomics in general. So there's a robust body of primarily survey-based literature out there about musculoskeletal injuries in GI. In 2009, Amandeep Shergill out of UCSF did a systematic review of 7 studies looking at the rates of musculoskeletal injuries in endoscopists. And she found a fairly broad range, but pretty common, anywhere between 37 to 89% of individuals had claimed some sort of musculoskeletal injury as a practicing gastroenterologist. A follow-up ASGE survey out of Indiana University of 684 participants, again, identified about half of the individuals surveyed had experienced at least one musculoskeletal injury related to endoscopy. This study sought to better identify what were the risk factors that might have contributed to these injuries. And they found that doing greater than 20 cases per week, 16 hours of procedures per week, or years performing endoscopy. And so many of you may already meet those first two criteria, but even if you don't, You can't escape father time. And so the longer you're doing it, the more likely it is you're going to get injured. Perhaps more sobering, of those people who claimed injury, over half of them required interventions to continue scoping that were above and beyond just standard kind of take a break. So they needed injections, prescription pain medications, physical therapy, sustained breaks, meaning several weeks out of endoscopy, or as far as surgery. Now we know that not only are GIs prone to injury, but that endoscopy is the direct contributor to these injuries. There was a study out of Mayo Clinic comparing internal medicine specialists that are non-procedural versus procedural. And they found a twofold higher increase of injuries claimed for gastroenterologists compared to non-procedural endoscopists, which is not surprising. A survey out of the AGA Women's Committee of 826 practicing endoscopists, which tried to control for pre-existing injuries prior to starting endoscopy, found that even if you control for that, the rate of injury increases twofold. They also found similar risk factors, meaning procedural volume, but they also found prior injury was a predisposer to future injury, which kind of underscores the importance of preventative care and identifying things before they become problematic, because once you get your first injury, there's a high risk that you may get future ones later. And then the other thing that they noticed or found was that a very, very small amount of those individuals actually had learned anything about ergonomics. They quoted a rate sort of low, but about 5%. Like Chris said, this is becoming a bigger topic. It's so much so that even in last month's Red Journal, there was a study looking at ergonomics. This to date is the biggest study, again, a survey-based study of almost 1,700 non-trainee practicing gastroenterologists. In this study, they found that up to 75% reported endoscopic-related injuries, of which 90% had more than one injury. They also did a multivariate analysis, again, consistently years performing endoscopy and hours per week. This was a gender-based survey. This was in the Women's Health and Gastroenterology journal issue. And then they tried to control for gender in terms of identifying locations or mechanisms by which injury developed. And they found that women were more likely to report endoscopic-related injuries in the upper back and the upper extremities, whereas men get in the lower back. And they postulated a few hypotheses, but nothing concrete. So I think it's fair to say that all of these studies, though it's just kind of a sampling, coalesce into a fairly clear and consistent picture. One, injuries are very common. Two, they're more likely the more often you scope and the longer you've been doing it. And three, we're generally not well educated. This study had 61% hadn't learned ergonomics, so not as low as 95%, but it was still pretty low. And for me personally, actually, it was during my time at Sinai where I kind of realized that ergonomics is important, because it's one of the anomalous years in your training where you're doing endoscopy all day, every day, without clinic or any other breaks in there. And so it tends to expose any potential weaknesses that you have already. So it's important to think about where we get injured. So in the hand and the forearm, there's a couple of places and joints that are important. On the left side, you have the abductor pollicis longus, which deals with the movement of the dials. And if you get injuries there, there's a picture of the tendon. That's the right hand, but that was the best picture I could find of the tendon. You can get what's called the Quervain's tenosynovitis, or sometimes called the colonoscopist's thumb. And that's just from pushing the big dial and the little dial on the left hand. If you move up the forearm, there's the left external carpi radialis, which controls wrist extension and abduction. And so when you strain that, you can get what's called tennis elbow. And if any of you have played tennis, you know it can hurt on the lateral aspect of your elbow as a result of that. Finally, on the left side, you can get injury to the flexor digitorum superficialis, which can give you carpal tunnel syndrome. That's typically from gripping the control section of the scope. On the right side, similar joints are affected, the external carpi radialis and the right flexor digitorum superficialis, same mechanisms. So there are other common injuries that we can develop in the neck, the shoulder. There's something called a biliary endoscopist knuckle that was coined by Jerry Siegel. There's a picture up here on the right, which shows his joint after placing several, probably 1,000 plastic biliary stents. You can develop lumbosacral strain and lower extremity injury. And in that aforementioned Red Journal study, looking at self-reported upper extremity and lower extremity injuries. This is stratified by gender, blue being men, women being orange. You can see that thumb pain, hand and finger pain, and neck pain are some of the most common locations that injuries can occur. The other thing that's important to understand with these injuries is that not all injuries created equal. So these are typically what we call repetitive strain injuries, so things that develop over chronic use. And as opposed to acute injuries, they tend to manifest differently. Either they're achy, lead to weakness, can be neuropathic. They're more a cumulative effect phenomenon. So it's not usually like a suddenly you scope and you start hurting. It's several thousand scopes later or 100 scopes, depending on how ergonomically poor you are when you start. And it's more likely to remain chronic. So this data is old. It's from the early 90s, but it still holds true today. Essentially, they were looking at disability claims in the state of Washington over several years. On this graph, the y-axis is the percent claiming disability. So everybody's at 100% at time zero. On the x-axis is months from the disability claim. And if you look at these graphs, they tend to call kind of asymptote to certain numbers. The top graph that's separate from the other three graphs is what a graph for carpal tunnel syndrome, which is a repetitive strain injury. And you can see at month 8, a fifth of the people were still claiming disability, whereas for the other acute injuries, less than 10% were claiming. So as is the case with these chronic injuries, it's a small fraction of those injuries and disabilities, but they account for a huge cost to the system in terms of lost work and so on and so forth. And I'll take a moment to give a brief detour on disability insurance. I think, as is the case with most insurance, the best time to get it is when you don't think you need it. So I think you should have the mindset of, I will likely develop an injury, which is pretty clear based on the data I presented, instead of I hope I don't get it or I'm okay so far. Now, there are a couple things to consider when shopping for disability insurance. Now, many of you or all of you may already have it. I know our trainees get it as they join, but there are a couple things, if you already have insurance, that you may want to look back at to see that you're covered for these various aspects. One of the things which is sort of intuitive is, how do they define disability? So the threshold at which disability, you have to prove that you're disabled in order to collect claims for it. Is it portable, especially for you that are trainees? If you have insurance there, are you able to take it from Sinai to other places? Is it own occupation versus any occupation? Meaning, are they covering gastroenterologists or endoscopists or any physician or any internal medicine physician? And like I mentioned from that Mayo Clinic study, we as GI doctors are twice as likely to be injured. And so we may not be best served with a general physician disability insurance. Does it cover short-term, meaning up to 52 weeks or a year, or is it long-term, meaning up to age 65? And there are various riders present. One is a future purchase option, which allows you to augment coverage. Most importantly, you don't need to get another physical exam for that. Is there a cost of living adjustment, meaning are you protected for inflation or your change in cost of living based on where you live? And do you get partial or residual disability benefit that covers partial loss of income as opposed to full loss of income? So for us as gastroenterologists, we can still work in clinic and see patients. So do you get part of that covered or not? And so I think it's important when we go back to these injuries to think a little bit about what is it that we're doing that's predisposing us to those injuries. And I think one of the key factors to take home is this idea of neutral posture. So neutral posture is defined as the resting position of each joint with the least tension on nerves, tendons, or muscles. Said differently, it's essentially the most mechanically advantageous way for us to use our muscles. So when our muscles are in non-neutral postures, you require more effort to get the same effect. So you need more squeeze for the same amount of juice, so to speak. So as an example in colonoscopy, when your left wrist is flexed 45 degrees, so halfway to 90 degrees, your actual grip strength decreases by almost half, 40%. So your ability to hold a control body, your ability to move the dials decreases significantly. Similarly, if you extend your left wrist by 45 degrees, your grip strength drops by a quarter. So though you may be physically fit and you may have the ability to do these things, you're actually creating hurdles for yourself and handicaps for yourself to actually accomplish the maneuvers that you want. Which then begs the question, how neutral are we when we do these endoscopies? And so this is another study out of Mayo Clinic in 2014, where they did a kinematic analysis of 12 quote unquote experienced endoscopists during 2 simulated colonoscopies. And you can see they wore these gloves on their right elbow and right hand, and they had little gyrometers that assess for movement in relation to space and speed and velocity. This was focused primarily just on the right wrist, and they recorded it with a magnetic motion tractor with all those various maneuvers: abduction, adduction, flexion, extension, pronation, and supination. And so when they did this study, it put out one of these graphs like this. So again, the y-axis is deviation from neutral. So the gray area is neutral, green area is the okay area, red is danger, and yellow is way out. And then the x-axis is time during the procedure. And the key take-home point from this study was that endoscopists spend up to 30%, and again, these are experienced endoscopists, of their procedure duration at the extremes of right wrist range of motion. Now, this is just one joint, so it's possible that other joints are less, or they may be more. But I think it speaks to the fact that experience, if anything, might propagate these problems as opposed to fix them. And though neutral posture can be changed, there are also non-modifiable aspects of endoscopy that should be considered. One of the things is hand size. So a study in 2008 was a survey study of GI fellows, over 200 fellows, and assessing their perception of how their hand size affected the way that they could pick up and learn and continue to grow in endoscopy. The median glove size was 7.5. Almost 80% felt that their hand size was important to endoscopy training, and 41% felt that their hands were too small to learn endoscopy effectively. 38 respondents had the glove size less than 6.5, of which all but one were women. A surgical study, which can probably be extrapolated to endoscopy in 2004, was also looking at the association of glove size and surgeon difficulty using laparoscopic instruments. And so here you'll see a graph of reported difficulty with certain tools stratified by glove size. So the small glove is the leftmost graph in each of those sections, and the large glove is the rightmost graph. And you can see on each task, and in particular the stapler, the small glove size led to increased reported levels of difficulty. And on the right is a distribution of the glove sizes based on gender. So the left graph is the glove sizes for the women, and the right graph is the glove sizes for the men. And so I think hand size and gender certainly are associated with each other. So I think another non-modifiable risk factor for injury could be considered gender. And actually in that same Red Journal article, I wanted to highlight another article published by Dr. David and Dr. Kumta and colleagues, where they did a survey of fellows and attendings. They were looking specifically at gender-specific factors influencing careers in advanced endoscopy. But there were some aspects that are relevant to what I'm talking about today. So 71% were women, of which 24% plan to pursue advanced endoscopy. But one of the key deterring factors for women was the fact that there was a lack of ergonomically designed equipment for women. So this aspect may provide some sort of selective pressure, which might affect why we see that women are underrepresented in advanced endoscopy. They found other factors, such as environmental factors, such as absence of same-sex mentors and workplace gender bias, as well as personal factors, such as family planning and fertility and pregnancy risks. And so this lack of ergonomically designed equipment is a good segue into how scope design is a culprit in the broader landscape of injury. And I'd be remiss if I didn't highlight how our institution here in Michigan played a central role in the modern day endoscopy. So I'll take you back to 1954 when Basil Hershowitz, a South African physician who was here at the University of Michigan in fellowship with H. Marvin Pollard. They were doing a journal club, a fellows journal club, where I was told they go to the local bars in Ann Arbor and read some articles. And they read an article in Nature on fiber optics. And so Hershowitz leaves that meeting thinking, hey, I'm going to start working on a scope that will use the fiber optics that were described in this paper by British folks in Nature. So in the ensuing couple of years as a fellow and as also a clinical lecturer, he develops a prototype flexible endoscope with a fiber optic bundle. And he's his first own patient as he looks inside himself. This is a picture of what that scope looks like. And you can see there's an inflation bulb to insufflate, and there's an eyepiece that you put your eye on, and there's a camera or a lens at the end. That scope sits in the Smithsonian right now. On the right is a picture of Abraham Lincoln and a stamp that was taken by that scope and connected to a camera. So in 1961, Hershowitz collaborates with the American cystoscope makers, publishes on a prototype in Lancet, and then brings the scope to market. The cost of the scope at that time was $1,650, which in today's dollars is about $13,000. In the ensuing several decades, there were multiple refinements to the scope. So they repositioned the lenses, they add four-way tip deflection and suction. And then the next kind of hallmark of the evolution of the endoscope occurs in 1983, when we developed the first video colonoscope. So no longer do we have to put our eye on an eyepiece, we can actually put it on a screen, and people can look together, and you can see what's going on there. And since that time, the evolution of the scope has just exploded. We have improvements primarily in optics and processing. So things like narrowband, near focus, confocal imaging, even artificial intelligence. All of these bells and whistles have been added to the scope to make it that much better of a device. But I think one of the things to think about is that there's been minimal parallel advances in the endoscope human interface. In other words, what we call human-centered design. So functionally, it's a one-size-fits-all device for a not one-sized workforce, as I mentioned with hand size and other things previously. And the analogy I like to give is that you imagine if you purchased a car and when you lifted up the hood, it had all the bells and whistles and the top of the line engine, but when you opened the door to get into the car, it looked like one of these things where there was kind of a bench seat with a non-adjustable wheel or a steering wheel and no heated seats, so to speak. So I think maybe it speaks to the lack of selective pressure in the endoscopic world that companies that do this still thrive, whereas if a car company did that, they probably wouldn't be particularly successful. And so this is where ergonomics comes into play. Quite literally, ergonomics comes from the Greek ergon, meaning work, and nomos, meaning laws. Defined as the study of the physical and cognitive demands of a task in relation to an individual's capacity. Said differently, it's how a job can be best fit to an individual, not how an individual can adjust to fit their job. And I think the discussion needs to be recentered on the idea that if you get injured, I think the temptation is to feel like it's my fault, something I did cause this to happen. And I think the idea behind ergonomics is that we should think a little bit about how the workplace is contributing to or preventing you from getting or remaining healthy. And so I think that's the key in ergonomics is to recenter that discussion. So when we think about fitting the job to an individual, we should think about who we're fitting it to. What's considered the Bible of ergonomic design in the workplace is Eastman Kodak's Ergonomic Design for People at Work, first published in 1983. And the general philosophy of this script is that you should accommodate a range from the 5th percentile woman measurements wise up to the 95th percentile man. And if you do that, you'll adequately cover enough of the bell curve to make it safe for everybody to use that device. And just to give you an example, just for hand measurements, you can see the span of difference in dimensions of width, length, and circumference from a 5th percentile woman to a 95th percentile man. So it's a pretty broad swath that you need to cover, but these are things that you should think about when we're making devices. And so when we think about how do we use ergonomics to improve the workplace, like I mentioned in the outline, it's important to prioritize those interventions that we perceive or those interventions that we know that have the biggest bang for their buck. And so this is the hierarchy of controls that was a recommendation of the Occupational Safety and Health Administration, or OSHA, and provides a hierarchy of effectiveness of interventions for ergonomic changes. And so you can see at the top is elimination, substitution, engineering controls, administrative controls, and PPE. The most effective at the top, least effective at the bottom. So what would this be in endoscopy? So elimination and substitution would either be removing the scope altogether or substituting for a new scope. Engineering controls would be adjustable monitors, beds, support stands, dial assists, which I'll go through. Administrative controls are things like ergonomic training and a safety culture, a timeout, your endoscopy schedule, and endoscopic maintenance. And PPE is endoscopist's technique, so micro breaks, stretches, and maintenance of physical fitness. So first, I'll talk about the top two, elimination and substitution. I think with the advent of therapeutic endoscopy, it's fair to say that we will not be able to fully remove the scope altogether out of our practice, and I think it's an important part of what we do. And so could we do substitution? Are there options for substitution? And as I looked through the OSHA literature, I found an interesting anecdote. So this is an example. There was a poultry packaging plant in the Midwest, and they were utilizing a butcher's knife for deboning. And that's a picture of that knife. And you can see when you're gripping that knife, you're abducting the right wrist. And so you can see it's pretty ergonomically unfavorable. And what this packaging plant found is that they had 100,000 increase in workers' compensation premiums for carpal tunnel, tendonitis, and other associated upper extremity injuries. So then they decided to switch to what they called a pistol-shaped knife. So you can see the wrist is a little bit more neutral and it looks like a pistol. And what they found is that over the ensuing 5-year period, they had line speeds increasing about 2 to 6%, and they saved about $500,000 in workers' compensation premiums. And if you look close enough in the world around you, you'll see other ergonomy-inspired modifications, whether it's the snow shovels, maybe the keyboard in front of you, moving straps, or gardening tools. And I think the idea is that when a space is in need of a tool, we race to get that tool to that space. But there's little consideration to the downstream effects of chronic use of these tools. And so modifications come along throughout this time to offset those types of issues. So is there a new scope on the horizon to meet these evolving needs? Here's an example. It's called the Endoscope out of Germany. It's a lightweight single-use colonoscope. It has a detachable handle. It has tip control via electromechanical assistance instead of Bowden cables. So Bowden cables are those cables that connect the dials to the tip of the scope. So as you know, the harder you move, the more the tip moves. With electromagnetics, it's not a pressure-based phenomenon. And it has retrograde viewing, and to boot, it actually moves itself on its own. So obviously, these things may not be coming right away, and I think it's important to think about what the inherent barriers to substitution may be. The obvious one is cost. There's an upfront investment to buy these devices and get them into the workspace. The other thing that may not be immediately obvious is that there's a lack of immediacy of return on investment. And so the analogy I've used here is things like TAVR for aortic valve disease. That's a very tangible cost savings when you start using that instead of open heart surgery. It's a little bit of a harder sell to say, hey, we should get all of these, spend several $1 million on these new scopes, and we will prevent injuries for a couple decades from now. And so I think it's a little harder to get that into the world. You have to make sure that that new scope is compatible with your accessories, your report writing software, your monitors. And we're just generally creatures of habits. We get used to certain things, and it's hard for us to change things. And said differently, is this idea of relearning conscious competence. And so this is a graph that depicts how we learn new things. And so if you think about how when you first learned endoscopy, you start with what's called unconscious incompetence, meaning you're not able to achieve the goal that you want, whether it's getting past the sigmoid or getting to the cecum, and you don't really know why. And then eventually you move to what's called conscious incompetence, meaning that you know that you don't know, but you can't really figure out how to fix it. Later, you get to what's called conscious competence. So as fellow trainees, that may be where you reliably get to cecum. And then you get to what's called unconscious competence, where you don't really have to actively think about it, but you can do it, much like those of us who are faculty who are doing kind of standard colonoscopy. And so to kind of hammer this point home, when we're teaching endoscopy, we have to, as faculty, drop down from unconscious competence down to conscious competence. So we have to break down the steps that we use during a task to communicate with our fellows to let them know how to achieve these goals. So when we introduce a new scope, it drops us all the way back down, and that can be sort of humbling and a little bit difficult for us to swallow as faculty. So let's talk about other things. So engineering controls, administrative controls, and PPE. So from the engineering control standpoint, there are indeed systems limitations. So our procedural templates are not often designed with injury prevention in mind. The daily template is not designed for built-in micro breaks. It's all about efficiency. You want to get anesthesia out early. You want to save money on facility costs. Your weekly template may not be sufficiently spaced out for endoscopy shifts either, what I call macro breaks. So you may be given 3 days of endo a week, but you may do them Monday to Wednesday. And that would be very different than if you did them Monday, Wednesday, and Friday, where you have those built-in breaks in between. And then when you're on service or on a holiday block or whatever it may be, it might hyper-concentrate your procedural volume. So I think at this point, I've painted somewhat of a bleak picture where we're all bound to sustain injuries and there's little to no hope for meaningful change in the scope or the system. But I wanted to switch to prescriptive ways that we can actually get better with ergonomics in general. And there are several interventions. The first thing is learning about ergonomics alone can help. So actually being here today with me and listening alone can help you. And I have 2 studies that'll illustrate that. The first is a study from last year that assessed the impact of simulation-based ergonomic training curriculum for fellows. So they took novice fellows, so beginning fellows, and gave them ergonomic training. That training consisted of a 1-hour lecture, much like this, a 5-minute video of an expert endoscopist doing a procedure for them to look at technique, and then a checklist that they would go through, which I'll go through later, that they wanted to pay attention to when they're doing procedures to make sure that they do all the right things. And then they compared this group to a historical cohort that wasn't given such training, so the fellows the year before. And then what they did is so that group before got all the identical same training, but not the ergonomic part. And then they took videos of each cohort performing 2 clinical procedures about 4 to 6 weeks later, graded on a validated ergonomic scale by experts. These are the results. So on the y-axis is the score for this clinical rapid upper body assessment score. Higher scores are worse. And the blue box are the pre-ergonomic intervention, and the orange box are the with ergonomic interventions. And you can see there are statistically significant differences and somewhat durable. This is about 6 weeks later for that initial training and that continued reinforcement. The second study was a survey of GI fellows 2 years ago, 156 of them, looking at endoscopy-related musculoskeletal injuries. Again, about half reported at least one musculoskeletal injury, but the important finding or relevant finding from this study here was that it appeared that having ergonomic training alone was protective against injury. So the 45% of those who did not sustain injury had received ergonomics training. So what about getting an ergonomic assessment by a professional? This is another study that's pre-proof ahead of print in GIE out of Duke University. They took 8 endoscopists, a single center study. They did a baseline assessment of demographics, pain, fitness level, and had all of these endoscopists complete a validated musculoskeletal questionnaire about sites of pain. They had a physical therapist then assess their static, meaning when they're standing, and their real-time posture, meaning their posture while they're doing procedures. And then they gave these individuals what they called an individualized wellness plan with recommendations, and they made a 6 to 12 month follow-up. And so you can see on the upper right, they gave recommendations on how they should stand on a day-to-day basis, what their posture should be during the procedure, what they can do in the procedure suite to optimize how things are situated. They gave them some exercises and personalized pain education. And so what were the findings of this study? So they found that pre-intervention, there were 22 distinct sites of pain identified, of which the back and the neck were most common. They spent about 3 to 6 hours, so a fairly significant amount of time with the physical therapist, with an average cost about $500. Post-intervention, 64% of those pain sites were reduced in intensity or completely resolved. So that intervention actually did make a substantial difference. And they made some recommendations for the procedure suite itself. So bed height, and monitor location. So that was one of the key components of this, this intervention, was giving them recommendations. And I'll go through what it is that they recommended to these endoscopists with you now. So they talked about the room layout, the monitor positioning, bed height, and how to handle the scope. And so I'll go through each of them. So the room the layout, there's essentially 3 phenotypes of the room. The first is in increasing levels of ergonomic quality from right to left. So the lowest ergonomic quality is what we call a bed-centered endoscopy room. So this is what you may better recognize as the travel case, where you've got the processor on the other side, you're draping the scope over the patient. And so it doesn't take a degree in ergonomics to know that that's not the most favorable situation to do a procedure. The next best layout is what we call system-centered, where you kind of fit yourself next to the processor, but the processor is next to you. You're not draping it over the patient, and the patient is in front of you. And the hallmark of a good endoscopy suite setup is what we call the endoscopist-centered suite, where the processor is behind you and the patient in front of you. And I think that most, if not any, units are situated this way. Now let's talk about the monitor itself. So the majority of studies looking at procedure-related cervical strain come from laparoscopic literature. So this is extrapolated from that, but I think it applies to us as well. The general goal is to limit prolonged neck extension. You can see on this image on the right what the vertebral processes look like when you have a stable inclination on the left, and then when you're looking up higher than you should on the right. So based on these studies, they found that the optimal monitor height was such that the top of the monitor is at eye level. So when you look directly in front of you, you should be seeing the top of the monitor right in front of you, the top, not the center. And what that does is that puts the center of the image about 15 to 25 degrees below the horizon. And that leads to a cervical spine position on the left, whereas if it's too high, it'll be like this. So if you were to build a unit from scratch and you wanted to get that 5th to 95th percentile rule, you'd want the bottom of the monitor to go as low as 3 feet to as high as 5 foot 4 inches, and you would be able to account for all of the people that you would want to. So what about distance? Again, the major determinant is monitor size and resolution. You don't want it so close that you're needing to move your neck around to see around, and you don't want it so far that you can't really see what's going on, which is relatively obvious. The optimal monitor distance is about less than 6 feet. So it shouldn't be more than 6 feet away from you for you to appreciate the true benefit of the monitor. So then what about lateral positioning? So we talked about height, we talked about distance, lateral positioning. So the monitor should be directly in front of you, which again is pretty intuitive, but you want to minimize the rotation of your neck, your spine, and your hips in relation to each other. And so here, if this is your endoscopist here, the thing I tell our fellows when I'm training them is that you want to envision a series of parallel lines. So one parallel line connects your two hip bones. A second parallel line connects your shoulders. And then there's a third parallel line that's between your ears. And you want all three of those lines to remain parallel to each other. And then you want those three to be parallel to a monitor face. And if you do that, you are ensuring that there is no rotational effect on your spine during the procedure. Some people can have the edge of the bed in front of them as well and have that be parallel, but that's not as much a requirement. It's the other ones that are important. And so this person is doing it correctly. Now, if you had somebody like this, where you're kind of craning your head ever so slightly to the right to look at the monitor, you're adding rotational strain on your neck that doesn't need to be there. So then let's move to the bed. Again, extrapolated from laparoscopic task literature. And it's important to think about, why does the height of the bed matter? What does it do if the bed is too low or the bed is too high? If the bed is too low, you tend to flex your trunk, which adds strain to your paraspinal muscles, meaning that those paraspinal muscles are activated to keep your upper body stable. And so you're constantly stretching those muscles the entire day. If the bed's too high, you abduct or abduct the arms away from your body, which adds strain to your deltoid and trapezius. So you're basically kind of lifting your arms away from your body for the entirety of the procedure, which is also suboptimal. So again, if you look at that same literature, we find that the optimal bed height is at elbow height or 10 centimeters below. For those who are not metrically inclined, it's about 4 inches. So an easy way to sort this out, instead of having a ruler with you, is when you stand next to the bed, the top of the bed should fall between where your elbow is and where your wrist is. And then you know it's a reasonably good height, because then when you bend, it's less than 10 centimeters. So how should we hold a scope? And for nomenclature's sake, we'll call the cord that comes off of the back of the scope the universal cord, and the portion of the scope with the dials the control body. And so I've included 2 pictures of how you may hold the scope in your practice. On the left, you can see, if this is your left forearm, on the left, the universal cord lies on the outside or the lateral aspect of your left forearm. On the second image, that universal cord comes between and drapes on the inner portion of your left forearm. At this point in the talk, if we were there in person, I would ask for a show of hands if you know which of the 2 you do. Some of you may not have a preference, some of you may not know. But from an ergonomic standpoint, one is more favorable than the other, and that one is what I call the medial cord, meaning you want the cord to drape on the inside of your left forearm. Now, as is the case in any of these situations, it's important to explain why is the case. It's not arbitrary. There's a few reasons. One is that it induces a slight counterclockwise rotation of the control body, as indicated by this yellow arrow, which seems sort of counterintuitive because it moves the dials away from your left thumb. But what it allows you to do is to recruit the other fingers in your left hand, namely your middle finger, ring finger, and index finger, to help your left thumb. Remember, I didn't mention those fingers as being primary culprits in injury, whereas the thumb is a huge one. And so you want to be able to use your other implements if you can. Additionally, the control body will then rest stably between the first web space of the thumb and the index finger. And so oftentimes I tell the fellows, when we all start, we tend to hold a scope like this, and we realize that if you hold it a little bit more like a platter, it's a little bit more stable. When you hold a scope like that, and the cord is on the medial portion of your forearm, it minimizes the extent to which you're pushing against the weight of the scope. So if you had this cord right here lateral to your forearm, every time you push on the dial, you're having to actually lift a little bit of the weight of the control body with your left thumb. How about your right hand? So I call it the bow grip, where you're kind of holding it sort of slightly and lightly. That's more ergonomically favorable to a tennis grip, which is typically the grip we see in our fellows when they're first training. There's a few reasons for that. It allows more tactile sensation of resistance. You have more sensory nerves in the pads of your fingers than you do in your palm, and so you can feel resistance from the colon. Also, you end up using a less strained muscle. So you use the adductor pollicis, which is the muscle between your thumb and the other fingers. and don't use the external carpi radialis. And so those of you who may squeeze the scope pretty hard with your right hand, we had a couple fellows who actually got injuries early on a couple of years ago. They got tennis elbow and they had to start wearing braces. And so it's important to try and convert to that means of holding the scope. Some people around these parts use washcloths or grip aids to decrease the strain of the tennis grip, which again, if you've played tennis, you know that the way to avoid tennis elbow is to have a bigger grip. And I'm not as huge a fan of it. I think it helps if you really need to use the tennis grip, but it does kind of reinforce this idea that that's the way to do it, when we should try to avoid that. There's this thing called a dial assist, which I had never been familiar with, but it's something that you may want to look into if you have issues with small hands in particular. And so it's imaged this green thing right here. And so you put it on the little dial and it makes the little dial bigger in size such that it's almost the same size as the big dial. So it makes it easy for your left thumb to reach that. Now this is made by Olympus, it's reprocessable. So you can purchase it and clean it and then reuse it. So that may be something to use. The other thing that we do when we do endoscopy that plays a huge role in our ability or our chances of getting injured is we stand a lot. And so it can contribute to pain and fatigue because you don't return blood supply from venous return. And you get low back pain because you're using those muscles to stabilize your posture. There was a systematic review in 2015 that looked at interventions that were effective for prolonged standing in the workplace. And there's two things that I think are relevant to us as endoscopists. The first is a cushion mat. I don't recall if they use them there, but the idea behind the mat is that it creates an unstable surface. So it makes you a little unstable in such that you don't lock your knees. And as a result of not locking your knees, you move your muscles more and get that muscle massage effect. And so this systematic review found that cushion mats are effective in the reduction of subjective complaints of discomfort and fatigue. So there's a lot of adjectives there, but I think in these types of studies, subjectivity is going to be the standard. And so the individuals who used it in the systematic review did find improvement in discomfort and fatigue. The other thing that people have been known to use are compression stockings. And those work by prevention of venous pooling. So you may not actually have edema at the end or appreciable edema at the end of the day, but you may pool venous blood at a higher rate than if you did have the stockings, if you're wearing the stockings, which might hurt your ability to recirculate blood. And they also found that this was effective in the reduction of subjective complaints, leg fatigue, pain, and swelling. For those of us who wear lead, that can magnify the ergonomic challenges of standing. And so here I've shown two physicians. On the left, he's wearing one-piece lead. On the right, it's a two-piece lead. In general, the recommendation is to wear the two-piece lead for a few reasons. One is that it takes half of the weight off of your shoulders by putting the second half of the lead on your waist. The second thing you may want to think about doing if you wear a two-piece lead is making the vest sort of tighter than you may think, such that you can slide your fingers underneath the lead between your top of your shoulder and the lead. And that ensures that you're not carrying the weight of that lead throughout the entirety of the procedure. Now, endoscopy also doesn't exist in a vacuum. And so you may be doing virtual visits or this Zoom meeting or writing notes. And so I think it's important to think about what can you do around endoscopy to make things better. So when you're sitting in front of the computer, and you can even look at your computer now, you want to have the same principle. So you want the top of your computer monitor to be at your eye level. You want your armrests of your chair to be at table height so that you're not inducing any flexion or extension on your wrist. And you want your knees bent at 90 degrees or slightly less acute. There was a systematic review of workplace interventions for upper extremity musculoskeletal disorders, and they found that resistance training and stretching in the peri-work arena was helpful in preventing injuries. So what might resistance training and stretching look like in endoscopy? So in the ASGE Learning Center called GI Leap, they have a video that you can, I think it's like $12 if you're an ASGE member. So I'd encourage you to get it if you think that this is something you're interested in. Dr. Raju in Texas, there's a ballerina who does resistance training and gyrometrics. And so she went through a couple of the stretches and resistance trainings that people can do during endoscopy to limit injury. So if you pull against a resistance of a glove, that helps with periscapular stabilization. You can do what's called shoulder release. So as you're pulling across against the gloves, raise above your head and bend side to side. When you're scrunching up your gown to throw it away, you can squeeze against that balled gown to reactivate your fingers. As you're washing your hands, you can do shoulder rolls to help release that tension there. I don't know if you walk around with resistance bands in your bag, but if you do, you can lean forward and back with that resistance band as well. And then pushing against the wall to stretch your back. And so you may, by no means do you need to do this on a procedure per procedure basis, but if you've got a long day, or if you're waiting for anesthesia for your next case or whatever it may be, this might be something to do in the interim. So I think putting it all together, how can you be ergonomically sound going forward? So first is you want an endoscopist-centered room layout. Again, you want the bed in front of you, the monitor in front of that, and you're the star. You're the person who needs to be comfortable and be able to do this. The monitor, the top of the screen should be at eye level. It should be visible without spine rotation and within 6 feet of the endoscopist. The bed height itself should be within 10 centimeters of elbow height, or 4 inches. You can consider compression stockings or a cushioned floor mat. The cushioned floor mat can help with knee hyperextension. And at this point, you could do what's called an ergonomic timeout, which I mentioned in that hierarchy of controls, but it's essentially, just like you're checking your narrowband imaging, irrigation, suction, you may want to just take survey of your surroundings and see, do I have a cushion mat? Is the bed okay? Is the monitor okay? And you may not need to do that out loud, but I think it's a good thing to think about in the context of starting or doing procedures. When you do the procedure, you want the universal cord on the medial left forearm. We went through why that's ergonomically favorable. And you want to hold the scope with a light bow grip on the right hand. And when you're writing notes, your endoscopy notes or your clinic notes, epic notes, whatever it may be, focus on posture during procedure note writing as well. And you might want micro breaks and intermittent stretching, like I mentioned, ways to improve how you can recover from the day or persist through the day. So in summary, injuries, it's clear that musculoskeletal injuries are commonplace for endoscopists and that there are factors that are both modifiable, such as a neutral posture, and non-modifiable, such as hand grip, size, or gender, that can contribute to these overuse injuries. The most effective measures based on the hierarchy of controls are primarily industry and organization led, but like I said, they're not going to be available tomorrow. And so I think if you prioritize ergonomics, whether it's by paying attention to what we talked about today, you can, via evidence basis, prevent disability going forward. That's it. Thank you very much. If you scan that QR code, it's got all the references and a couple of videos as well.
Anoop, that was a fantastic talk. Thank you so much. Going to open it up to questions from our audience. Dave.
Anoop, that was terrific.
Thank you.
Really good. And yeah, since you've been here, just to head off a couple of questions. So we changed the couple of the rooms that were set up the way that you had as the worst possible way to set them up, which was doing upper endoscopies across bodies. We moved the all the gases and the electricity and stuff, so those rooms were reset up, which was good. We actually had all the monitors moved down. They're not down as far as they should be. But that has to do with other stuff, because the endoscopy suite in the hospital wasn't designed as an endoscopy suite. So there's some stuff in the way, but actually the monitors have been moved down substantially to try to get them exactly at eye level, which is, I think, really good. And we ordered those mats a couple of months ago, actually. So we're waiting for them to come in. So there's lots of, but the information you gave was terrific, and I really appreciate it. So I have a question for you, because it didn't come up there, but so a good chunk of the world is left-handed versus right-handed, and this seems to be something that is designed for right-handed people. So did you come across anything that deals with people whose dominant hand is left?
Yes, I did. That's funny. Somebody else had asked me that question before. A couple of studies I cited tried to control for handedness in the likelihood of injury or the location of injury. Granted, these are self-reported and these are survey studies, but they did not identify anything about handedness which predisposes to a specific set of injuries versus others. I do think, though, that The device in general seems to be designed for right-handed individuals, but I don't think it contributes necessarily to injury per se, at least from the data.
Anoop, thanks for the great talk.
Sure.
The topic has been increasing in its popularity and relevance, which is really good. It was sort of like a culture of just scope and just make do with it. And there have been some injuries to folks in our division for sure, and other colleagues of ours across the city. One of the pictures you showed was, and Jerry Way actually ran around the unit a year or two ago asking us where we put the universal cord. And when you showed that, I just started laughing because one, I don't remember whatever came of that. And two, I don't think anyone knew what was better or worse. It was sort of like, what are you used to doing? And then you showed an image where the left hand was actually kind of like the platter.
Yeah.
Like you had talked about. Is that a preferable position? Because I actually make my fellows put their hand back up again because I feel like this is putting a lot of torque on your arm.
I mean, personally, I tend to do the, if you call it as I called it, the platter method. I think that one of the things I noticed, at least when you're looking at the scope, usually is if you're holding it up vertically, there's usually kind of a sharp angle when the cord is coming out from the bottom of the scope. And so I think mechanistically that bend almost functions like a loop in the sense that it absorbs a lot of the movements that you may have, or even the cables itself. So we typically hold them like a platter. We actually also, in terms of the location of the cord, had a similar experience where we're like, what do you do? And what do you, and we found that there was a huge amount of heterogeneity. And I was reading the citation for that slide was from Roy Satikno and Tanya Kaltenbach, and they went through how they ergonomically do these things, and they gave a pretty compelling reasons of which I highlighted why having the cord on the medial portion of your left forearm is ergonomically favorable, and it kind of validated what I do because that's the way I do it. But I'll say that old habits die hard, and so I think you're going to not get people who've been doing it for a long time to change. I think from our fellowship standpoint, we've made it a priority to try to get these interventions in early when fellows are learning. We've got posters with all this stuff in all our endo rooms to kind of remind them to do those things when they're first starting. Because I think once you pick up a way to do something and you do it well, you're not going to want to change it.
That's great. The other question I wanted to follow up on that is one of the things that's changed since you've been here is we've eliminated the male GI fellow, apparently. We are a fellowship of all, that's all, we have all women in the general GI fellowship right now. And you made a mention about the hand size, and that can be an issue. And I probably embarrassingly tell them when they're like, the scope head is too big. And I'm like, just reach over. Right, you'll get to it. My mentor is Mark Shatner, who's a tiny little man at Sloan Kettering, and he has small hands. And he always said, if I can do this, anybody can do this. But that's probably not the right mentality. So when you talked about dial assist, I never knew that device existed. Have you had any, have you used it? Or do any of your female colleagues use it, or anyone with smaller hands? And what are your thoughts?
So maybe the efficient way to answer that question is that when I didn't know about it until I started reading about this stuff. And then I shot a text to our Olympus rep, like, hey, do you guys have this? And he's like, I've never heard of this thing. And he's like, let me kick it up to the leadership or whatever. And 3 weeks later, he said, oh yeah, apparently this thing exists. So that might speak to the extent of which this has been adopted on a day-to-day basis. We discussed this topic in our grand rounds a couple of months ago. As far as I know, nobody's pursued that, but I do think that it's probably something to think about investing in, particularly in a fellowship that has 12 female fellows. I think that's particularly helpful, having that ability with small hands to minimize that. It may also be useful for those people who are recovering from an injury. So if you have a left APL injury and you're getting back on the wagon and trying to do these things, having that dial assist might help to minimize the extent to which you're re-aggravating the injury that exists. But to more succinctly answer your question, we have not used that device.
Well, I've already texted our Olympus rep, so we'll see what happens.
Right, as did I during the talk. I'd never heard of it before either, and it would be a great thing actually.
From what I understand, there is a disposable one as well,
Yeah.
and this green one is a reprocessable one, and so I think that, you know, depending on your throughput for that need for that device, either one should probably be reasonable to have.
Thank you.
Anoop, it's good to see you.
Yeah, likewise.
That was really an outstanding talk. I think it's the best talk I've heard on endoscopic ergonomics, just in terms of outlining the problem, how comprehensive you were, and the suggestions that you provided. I have two questions. One of the things that always comes up is whether or not, you know, you should take your right hand off of the insertion tube to try to, you know, help adjust that little dial, the little wheel. And you mentioned the, you know, that Olympus assist device. I think I had this sort of bias when I started that, you know, you should really be fixed and keep your right hand on the insertion tube. And I think some of that comes from a lot of the therapeutic maneuvers that we do, that you need to have your hand on the insertion tube for stable control. But I've realized that, you know, we do fellows scope training a lot, that because of hand size, and I think the scope technology is not adapted, as you mentioned, to fit that sort of 5 to 95%. I see a lot of the fellows either with smaller hands having to move their right hand to adjust the little wheel. So I'm just wondering your teaching techniques with regard to that specific aspect. And then second question is, Atul Gawande had an interesting editorial probably about 8 or 10 years ago in the New Yorker, that no matter how well trained people are, you know, very few people can sustain their best performance on their own. And, you know, that comes up all the time with professional athletes who are really at the peak of their sport, of their game, but they all have coaches that are there so that they can continue to improve and maybe point out, you know, things that they can work on. And I think I'm curious to get your thoughts on sort of the endo athlete and endoscopic coaching, you know, to have someone like, you know, like a Jerry Way watching you, or, you know, Dave Greenwald, Chris DeMeo, Satish watching you, and, you know, maybe one procedure for half a day to, you know, give some pointers, because a lot of this is, you know, driven on the endoscopists themselves to do the stretching, to do the ergonomics timeout, but sometimes having someone else watching that knows the position that you're in may be beneficial. So just your comments on those two questions.
Yeah, no, those are great questions. I'll answer the second one first. I think, yeah, you know, I mean, who's to say that, you know, Roger Federer needs a tennis coach, right? You'd think that if you're the best in the world, you don't need those kinds of things. But I think it's important for us to remain on top of things. And I think one of the dangers is that people adopt this, you know, once you finish your fellowship, that's kind of, you leave with that cut, and that's the way you're going to be doing things for the rest of your career. I know in Europe in particular, they're pretty forward with these things. Like, they have pretty frequent and regular peer-based feedback where endoscopists stay in the room with them and make recommendations. I think that that's something that's important. We here, I can tell you, have struggled with that because we have some senior people who I think are not particularly receptive to feedback, which is okay. But I think when we have new hires, even if they've been faculty at other places, we have individuals spending time with them. And so there is this concept of the endo athlete, like you mentioned. And so I think it's important for us, that also kind of keeps us humble too, knowing that you're not perfect, and our colleagues. And so sometimes I'll hang out with my therapeutic colleagues and just see kind of what they do, just to see those things as well. The first question about the right hand part, I'm okay with that idea, meaning of removing your right hand off of this insertion tube to move it over to the little dial. And in fact, I use that as a technique to illustrate the fact, particularly for early learners. I think there's this temptation to feel like you need to have the scope held at all times, and the minute you let go, it's going to fall back or it's going to go somewhere. And as you know, when we're doing large EMRs and stuff like that, the key to doing this technique, as Chris hammered in me as well, is to have both of your hands, having the lesion at 6 o'clock and potentially moving your body, and then being able to have all your control up here. And so I use that as a way to tell them that you don't have to have your hand on this tube at all times successfully complete it. And I, even myself, I think I'm 7.5 from a surgical glove standpoint, and I still use my right hand for the little dial as well.
I think along those lines, one of the things I learned from Jerry, and not having trained at Mount Sinai, but I've seen Jerry, when I was a fellow giving talks around the city and NYSG and such, was to use your right hip to pin the loop of the scope against the bed. And it acts as a third hand, and it frees up that second hand, like Nikhil was saying, like you were saying, to really give you another hold point or vantage point. I'll just say, and I mean, this is a super important topic that I am unfortunately acutely aware of. If people don't think this is real, I've had surgery on my left elbow for tennis elbow. I've had steroid injections in my right elbow for tennis elbow. I'm dealing with left biceps tendonitis, and I've recently been diagnosed with a pinched nerve in my neck with decreased strength in my right arm. So this is something that I am struggling with. I am keeping the NSAID industry intact, and it scares me, to be quite honest with you. And I think Bruce can probably share a story. When I was a trainee, a fourth-year fellow up in Boston, one of the pioneers in the field of ERCP was Bob Shapiro. And I think, and he was probably, Bruce, I don't know, 60s or 70s, probably when I was there. And I think he had most of his joints replaced. His hips, his shoulders, he's had surgery on every joint. And, when I was a fourth-year fellow, I didn't think anything of it. And now that I've been doing this for over a decade as an attending, it's caught up with me. And I have a lot of my career left. So it's something I am acutely aware of. I try to teach our fellows. I try to teach our staff. But I don't know what the future holds for me. And I don't know, Bruce, if you have any thoughts or comments.
Well, before people get too scared about the Bob Shapiro story,
figure out that cloning problem, and then I'll be okay. But
yeah, he is more titanium than bone. I think you're right, but his issue really is on top of all the stress and ergonomic issues of endoscopy, and he's been doing it for so long that the understanding of ergonomics have certainly evolved over the many decades that he worked. But also he was steroid dependent asthmatic, and so the steroids really were the major issue for him, I think, on top of the ergonomics.
Peter.
I just wanted to say that this is getting a little depressing, guys, but as someone who's been doing this for over 40 years, I think it's important to regard endoscopy as if you were doing a workout. And a lot of it is of importance, which you touched on, but really didn't go into, is what you do when you're not endoscoping. Stretching before you start, stretching after you're finished. I always thought one of Jerry's secrets was that his hobby is being a magician. And I've always thought that what's helped me is taking piano lessons and playing piano when I'm not doing endoscopy. And I think that you have to regard it as if you were doing an athletic event, and your injuries, just as it is with athletics, will decrease, I think, if you stretch before and after, and also try to relax. There's a lot of tension in that endoscopy suite, especially the fellows who are struggling or difficult cases. And I think that tenses everything up, and I bet that contributes to injuries.
The fellows have any comments or questions at all?
I think we're all just, sorry, go ahead. Sorry, I was just going to say, I think we're all just relieved to be talking about the small hands situation, and that there are potential adjustments, and that it's acknowledged that it's challenging, because it is definitely harder than just sort of getting used to it, especially for those with smaller hands. I have bigger hands, so that's still small, I guess, for the earth. I don't know, but it's very reassuring. I really loved your talk. Thank you so much.
Sure.
Yeah, thanks. That was a really great talk as well. I think as somebody who's like now learning ERCP, particularly maintaining a neutral position when you have to make all of those body adjustments, especially with supine ERCP, I find particularly challenging. I don't know if you have additional tips for that specifically.
Yeah, I mean, I think one of the things you'll pick up as you learn ERCP, and I think that it actually helped me a lot with my colonoscopy performance and general endoscopy performance, is understanding the extent to which, body movements and how you how you turn your body can make just as much movement on the scope as torquing. And you don't want to hyper focus the workout, so to speak, on a couple of joints. Like you want to spread the wealth. And I think with the RCP, and as we're getting alternate anatomy and edge cases and all these other things, it makes it that much more complex. And I think it's just important to listen to your body. These things, it's all about preventative care. You may not be injured now, but I think, particularly that year is long and it's tough. And so just, take care of yourself.
Chris, I know the hour's late, but two very quick things. The first is thanks for mentioning Jerry Siegel and showing his hands, because Jerry's been talking about this for 50 years. So sort of out there ahead of it. So great to acknowledge him. And also the Red Journal study that you cited was basically authored by a lot of people on but thank you for mentioning that. It was really nice to see.
No, not a problem.
Jerry, any final words? You're muted. You're muted.
Yeah, you're muted.
Unmute your microphone there.
Yes, I've been doing endoscopy for over 60 years, and I never had any occupational injuries.
Of course.
And my hands are small. I wear small gloves, and I think that it's important to be more relaxed when you're doing endoscopy. And I think everything has to fit. The table has to be the right height. You have to be centered in your domain. And I think you have to relax when you're doing endoscopy. I think being tense all the time is not good. So I think that once you get accustomed to using the scope, you can relax more doing procedures, and you don't have to be so tense all the time.
We can't all be like you, Jerry, getting through without ever getting injured.
All right. Well, the hour is we're well past the hour, but again, Anoop, thank you so much for a fantastic talk. I think everybody got something out of this. I think it's going to have a huge impact on everyone's practice, from trainee all the way up to seasoned veterans. So we greatly appreciate it, and it's great to see you again. And congrats on everything going so well so far.
Yeah, good to see everybody. I appreciate having me.